Welcome to another episode of Fresh Natural Live. It's Monday evening, and happy Juneteenth to all of you and all of our listeners. I hope you had a great weekend, and I hope your Monday's going well as usual. And as usual, we have a great show for you tonight. We're going to be talking about peripheral arterial disease. Many of you may be aware of that. If you have relatives who are smokers, who have coronary artery disease, or who have diabetes, you may be aware of issues related to peripheral arterial disease. Anyone who's had amputations, who've had lower extremity vascular surgery, likely have had it due to peripheral arterial disease. So we have a great show. I'm going to review a New England Journal article that gives an overview of this. There's a little case presentation that we'll discuss. And so I'll talk about some of the basic science and what's discussed in the medical literature. We'll then take a break, and then I'll come back, and myself and the panelists will give our take on things. I'll share my thoughts in terms of how I manage patients with peripheral arterial disease. It's a little bit different than what's in the medical literature, but I think you'll find it quite interesting. So sit back, relax. We have a great show for you tonight. Okay, welcome back. Welcome back. As I said, we have a great show tonight. We're going to be talking about peripheral arterial disease. However, first I'd like to welcome my friends and colleagues. We'll start with Dr. Pamela Atkins. Hello, Dr. Atkins. How are you doing?
Hi, good to be here. I'm doing well. Thank you.
So I imagine you guys treat a number of people with peripheral arterial disease. So I'll be looking forward to getting your take on things. And so it'll be interesting to see, how similar our different perspectives are. I want to next invite Isosa. How are you today, Isosa?
I'm good. I'm really good.
So which continent are you on this Monday?
I'm in the USA where it is Juneteenth.
So I was teasing you about that. Sosa's back and forth. She's got a special project I'm not going to mention going on in West Africa. So I'll just say that much and leave it alone. But anyway, welcome back to the show.
Thank you.
So that's Dr. Palmer. How are you today?
I'm fine.
So there's a rumor you have some special guests in town. So we might talk about that a little bit later. And of course, Dr. Floyd Atkins, how are you doing?
Doing wonderful.
Now, this whole issue of peripheral arterial disease, I'm sure, is something that you dealt with a lot in your practice because, the image that I shared on the show, the thumbnail image shows a person with a gangrenous foot. And so I'm sure you've seen a lot of those images or patients in your career. And so I'm sure you're going to have a lot to say about this tonight.
I'll share some horror stories with you later.
So anyway, so let's get started. We've got audience here tonight. And hello, everyone. Good evening, JW, etc. Let me get into this. As I said, I want to start off by reviewing this article from New England Journal. It's on peripheral arterial disease. I apologize that I didn't share the link in the notes, but I will go and revise the notes. So for those of you who go back and look at the replay on this, you'll see the link to this article in the notes. But you can actually just look at this title and the subauthor's name and do a search on the peripheral arterial disease New England Journal, and you'll be able to find it. But the New England Journal does a number. When they do the reviews, sometimes they'll do a case scenario. So here's a patient they talk about who's a 61-year-old woman with a 3-year history of discomfort to the right thigh on exertion. Now, I'll back up and say, exertional symptoms typically are vascular related. So if you have exertional chest discomfort or exertional shortness of breath, that could be related to coronary disease. If you have exertional limb discomfort, that could be related to peripheral vascular disease. So anytime you have a situation where exertion either brings on or exacerbates or makes worse symptoms such as discomfort or the like, you tend to think of a vascular problem, largely because with exertion, you're increasing a demand. So from the standpoint of coronary disease, when you exert yourself, you're increasing total body demand for oxygen, particularly, therefore, the heart has to work harder. And so its demand for oxygen increases rather. And so when you exert yourself, the need for oxygen delivery to the arteries. Now, the coronary artery is a little bit different than other vascular beds, I should say. The coronary myocardial tissue. With myocardial tissue, it extracts about 95% of oxygen from the blood that's delivered to it, compared to, say, in the periphery, it extracts about 75% of the blood. So, for instance, if you need more oxygen to the coronary arteries, there's only about a 5% amount of increase that you can do by just extracting more. But with the periphery, there's about a 25% hedge. So, for instance, if you need more oxygen in the periphery and say those arteries are blocked, you may be able to extract more. So maybe you extract from, say, 75% to 85 or 90%. But in the coronaries, you go from 95% to, say, 96, 97, but not much more. You probably can't extract that much more either. So the increase in oxygen delivery, or I should say the requirement or meeting the requirement for increase in oxygen needs for coronary or heart muscle tissue is more strictly tied to increasing flow. So if the arteries are blocked or not able to dilate for the heart, then you're more likely to have symptoms such as, chest discomfort or shortness of breath sooner than, say, for the periphery. Having said that, you can probably go longer with peripheral arterial disease without symptoms than you can with coronary disease without symptoms. Even though lots of people have coronary disease without symptoms, you theoretically can go longer with peripheral arterial disease because the tissue bed, muscles and the like, will simply extract more oxygen in the setting of a certain amount of disease. So this patient had 3 years history of discomfort to the right thigh. And so in theory, she may have had disease for much longer than 3 years. And that's kind of the point I want to make, with that little miniature dissertation. She had a history of coronary artery bypass. So now she's 61. She had coronary artery bypass after a heart attack, that's myocardial infarction, at the age of 55. And she had hyperlipidemia. So now she had bypass surgery, heart attack at 55. That's 6 years prior to, this presentation. And so, this coronary bypass, the coronary artery disease developed over decades. So it's pretty easy to say that she had probably significant, if not advanced coronary disease in her 20s or 30s. That wouldn't be too much of a stretch in her, and probably very likely had significant peripheral arterial disease around the same time. She was taking a atorvastatin, 40 milligrams daily. She had a 50 pack year smoking history. So pack years, the number of years times the number of packs. So if she smoked 1 pack of cigarettes for 50 years, so maybe she smoked since she was 11 years old, then, that would be a 50 pack year. If she smoked 2 packs of cigarettes for 25 years, that'd be a 50 pack year smoking history. So she may have had maybe, 2 packs and then 1.5 packs for maybe 30 plus years, something like that. But she smoked very significantly. At the time of presentation, she was on 8 cigarettes a day. That's a little less. I think that's a little less than half a pack. I think a pack is 20 cigarettes. I remember my dad was a smoker, and I think he smoked those Lucky Strikes. I think there were 20 cigarettes per pack. My familiarity is not from personal experience, but from, seeing my dad's cigarettes. I thought I'd point that out. Anyway, so blood pressure time wasn't too bad, 126/82. And then there was a bruit over the right femoral artery. A bruit is just a sound that you may hear go something like that. And whenever you have turbulence of flow, it causes a sound. So sometimes people have like a murmur in the heart. So you hear that swishing sound where you shouldn't hear swishing sound. So over an arterial bed or arterial body, we call it a bruit. Over the heart, we call it a murmur. So if you hear a swishing sound, that's the sound of turbulence, which in this case could be a sign that there's some narrowing in this artery at this point. So if you think of it this way, if you had water going through a hose or some kind of a tubular structure, and many people have done this, water coming out of a water hose, and the tip of the hose is coming out and it's flowing kind of smoothly. And you put your finger over it and create like a little stenosis, not only you cause some spattering of the flow, but you can make a little noise. And that's similar to what you would get with a stenosis, which we would hear a bruit in the case of an artery, or a murmur in case of blood going through a stenotic valve in the heart. So this is what she had. So then, they pose this question: how would you evaluate and manage this case? And so then we go into this discussion on peripheral arterial disease. Now, as an overview, there's a big differential in peripheral arterial disease. We're going to be talking about what we call atherosclerotic disease, which is due to atherosclerotic plaque as a result of buildup of plaque. But people with vascular problems, such as for instance, lupus and other type of systemic vasculitides, can have peripheral vascular disease that can affect lower extremities, that can affect kidneys or the like. But that class of people we won't be talking about today. This patient clearly has the garden variety peripheral arterial disease related to atherosclerotic plaque, mostly built up due to metabolic problems, lifestyle in particular. The two broad subtypes, they say proximal disease, which involves the iliac and femoral popliteal locations, is the distal part. So really above the knee and below the knee are really the two areas we talk about. It affects 8.5 million people in the U.S. and 200 million people worldwide. This number has probably grown in the last couple of decades due to the exportation of our poor lifestyle, and we'll talk about some of that toward the end. It's about $21 billion in costs in the U.S. alone. So, some of the basic clinical points they make here: 200 million persons worldwide, 8.5 million in the United States. Now, we're going to talk about this later. Non-invasive vascular testing is the way to go with people with suspected peripheral vascular disease. And the treatment, the main goals of treatment. Now, here I want to highlight. So the goals of treatment are to maintain reduce cardiovascular risk, improve functional capacity, and they mentioned supervised exercise, increased walking distance. Now, cilostazol, which is an agent that can give some improvement in vascular function and some lack of platelet stickiness, is used, and they talk about this. And then they say if that doesn't work, conventional angiography and revascularization are the approaches. But I'm going to kind of go through some of this, and this is what's recommended. And then after the break, I'm going to kind of break down what my thoughts are and get some of my colleagues' approach to this as well. So the 1 year incidence of cardiovascular death and myocardial infarction and ischemic stroke was higher among persons with peripheral arterial disease than among those with coronary heart disease. Now, let me pause there. So, vascular disease is a systemic problem. And if we saw with the patient that was presented, she had bypass surgery at the age of 55, then she's more symptomatic now with peripheral arterial disease. I alluded to the fact earlier that you likely become more symptomatic with coronary disease sooner than maybe with peripheral arterial disease. However, some people can be asymptomatic or be symptomatic and not really pay attention to it with coronary disease for a long time and not present. But the point of emphasis here with this comment is that the real issue in terms of mortality with peripheral arterial disease is cardiovascular death. And so these people die from heart disease. Now, morbidity is linked to both cardiovascular issues as well as amputation. But peripheral arterial disease in and of itself, blocked arteries to the lower extremities, rarely kill people. When they come in with gangrenous, feet, rarely, unless, they refuse surgery, we can just, chop off the foot, amputate the leg, and these people, survive this. So from the standpoint of the peripheral arterial disease directly causing death in and of itself, we typically don't see that. But these people don't just have peripheral arterial disease, they have coronary disease. So anybody who's been diagnosed with peripheral arterial disease likely has significant coronary disease. Even if they don't have a significant narrowing, they may have an unstable plaque in the arteries of the heart. So the need for peripheral revascularization and amputation is about 1 in 4 over a period of 4 years. Ankle brachial index, which essentially we measure blood pressure in the lower extremity, the ankle, the posterior anterior tibial artery, and we compare that to the brachial arterial pressure, and we do a ratio. And if it's 1 to 1 or 1.5 to 1, it should be normal. But if it's less than 1, so in other words, if the systolic blood pressure in the ankle area is, say, less than 90% of the systolic blood pressure in the brachial area, then you likely have significant peripheral arterial disease, and then more workup or intervention needs to be done. So this ABI, or ankle brachial index, is an important test. We do it a lot in our patients who are at risk, particularly diabetics or people who are have a history of smoking or other things that make us suspicious. We look for that. So in other words, if you have an ABI less than 0.9 or 0.9 or less, you have more than twice the mortality. And then mortalities, again, is going to be for coronary artery disease compared to an ABI that's in the normal range. So just think of it, just 0.9 is just, 0.2 off in terms of, the low normal of normal range. I know there's an upper limit. If it's greater than 1.4 ABI, then that's probably a sign of arterial stiffness, and you probably need to measure the ankle toe index. And so a toe brachial index, because you may have calcified arteries that are very stiff if your ABI is like 1.5 or 1.6. And so that could be a sign of vascular disease as well. So how do we screen? Typically, you're going to start with a clinical suspicion. Someone who's a diabetic, age 50 or older is a diabetic. We actually screen, pretty much all of our diabetics will screen. So we're saying, can see advanced disease, people in their 30s and 40s with diabetes. So even though they say older than 50 with diabetes and smokers with diabetes, we tend to even screen lower than this in my clinic. Persons who are older than 65, you want to screen as well, because age increase, the prevalence increase with age. The tricky part about this, you can have individuals who have pretty significant disease who are asymptomatic. And we've seen individuals with ABIs of 0.5 or 0.6, and they have no symptoms whatsoever of significance, but they're at increased risk of having a problem. They can have exertional discomfort, muscle cramps, similar to what the patient have. And then you have a subgroup of people who present with acute or chronic limb ischemia. And these individuals are people who may have symptoms for a while and ignore it. And then what happens is maybe they get an injury to the foot or whatever the case is. Whenever you get an injury or a cut or something, there's an inflammatory process that occurs. And with that inflammatory process, you need to have adequate blood flow to that area. And adequate blood flow frequently means increased blood flow. So let's say you have your foot, there's no injury, there's no cut or anything like that, and you're going about your business, then your flow is important because you're walking, there's a lot of oxygen demand on your feet. And in fact, the reason why you probably need more flow to this lower extremity, remember the ABI needs to be greater than 1, ideally. And so that's because we walk on our feet, not on our hands. If we walked on our hands and not our feet, then the ABI can be less than 1. But there's already a increased demand on the lower extremities because we are walking on the lower extremity. There's a lot of vascular demand there compared to our arms. Maybe we walked on all fours, so it'd be equal. But long story short, if you increase that amount of demand with an infection, a cut in your foot, a cut in your toe, then that cut has to be healed. So even more flow is required. So if there's compromised circulation, those arteries are blocked, they're stiff, they're not able to dilate adequately, then they can't deliver more oxygen, oxygenated blood, and more immune cells to that site that's injured. So then what happens that if you get an infection or whatever, the infection or invading agent takes control because the immune system is like a freeway. You got a robbery going on, at a building, and the exit to that building is, let's say, off exit A, but the freeway's backed up because there's a block. They're doing construction, so there's only one lane. And so the police or fire that's trying to get to that building where there's a fire and there's somebody held hostage, the police can't get there. So because they're blocked, the flow to that area is impeded. So the same thing with your immune system, the circulation is impeded. The good guys can't get to that site. And so what happens, the bad guys take over. So the infection gets worse. And then you can get people with gangrene. So some people can present with this advanced disease because they've had either subclinical or asymptomatic or minimally symptomatic disease, and the disease gotten worse, and then they step on a nail or scrape their toe or get some injury, and then they present with an acute or chronic limb ischemia and gangrene or something of the like. Now this diagram here, it shows you what we look at when we do some non-invasive testing. Now you can get these waveforms when you're doing a Doppler. So we have a vascular tech that can do Doppler studies, so you can look at the arteries through echo, through a Doppler signal, as well as having a direct visualization with echo Doppler. And so we can look at the arteries, look at stenosis, look at flow, look at calcification in the arteries, and also do a Doppler waveform. Now on the left here, this is abnormal. This is reduced. We call this biphasic, but this is really not biphasic. I would call this monophasic because you get one hump here. It's really not. This could be artifacts. It's a hump, and it's really one monophasic. On the left here, you see triphasic, and this is normal. You get up, down below the baseline, and back up again above the baseline. So you get one phase, two phase, three phase. That's what you should see. So you see triphasic, 1, 2, 3. So some people can go from a normal triphasic to a biphasic. So a biphasic would be up, down, below, and it would come up but not come back above. So it would come back up like that and level off. That would be biphasic. So the progression of these would be triphasic to biphasic to monophasic. And here you see monophasic and triphasic. And so these are the two extremes. And so they're showing it at different levels that's measured through the ABI. And so you can see by just looking at the waveform, you don't even have to look at the ABI measurements, but just by looking at the waveform, you can see the disease here. But they do give you the ABIs here. Okay, so they take the highest systolic pressure and then they measure it here. This is 1.01, 0.98, 1.02, and 0.99 on the DP. And so compared to 0.55 on this side in the dorsalis pedis, and posterior tibial is 0.56. Here you got 0.56 and then 0.58. So here's disease side on this leg compared to pretty much normal. This might be somewhere close to borderline, but you round it up to 1.0. So pretty much low normal to borderline. So this is advanced disease. But notice that even though these numbers are kind of barely in the normal range, the true normal you look at is 1.11 to 1.40. So you know there's some disease in this leg, and it's not unusual. It would be, even though you have triphasic waveform, but it's probably very, very early stage compared to advanced disease here. So non-invasive testing, ABIs, as I mentioned, and let me just sort of magnify this and share this part here a little bit more. So as we talked about, from 1 to 1.3, values of 0.91 to 0.99 are borderline. So we saw on that left leg, it was borderline, even though it had triphasic waveforms. The ABI greater than 1.4 could be due to poorly compressible arteries. So you may want to do a total brachial index, as I mentioned earlier. Disease, they kind of break it down to mild, moderate, severe. Less than or equal to 0.9, and you go from less than 0.70 to less than 0.5, and then less than 0.5 or less than 0.125. What we do is we do serial measurements. So, for instance, you may have a patient who's, say, living in this range here, and maybe you're doing your therapies and lifestyle things. And I've had patients will come in, and they're normally like a 0.63. And then they'll call us, look, I'm having some tingling and some pain in my leg. We come in and do an ABI. And let's say, 2 months ago it was a 0.65, and all of a sudden it's a 0.35. And I've had patients like this, and right then and there, I'll send them to the hospital. We'll start them on intravenous heparin and some other things, and do an arteriogram and make a decision in terms of what to do from there. But you can go from moderate to severe, or even mild to severe, mild to moderate in a short period of time. So it's not only the amount of severity, but the delta. So if you go from normal to mild in about a few weeks with symptoms, then that's a rapid progression. Or mild to moderate, it's a rapid progression. So sometimes, one person with a 0.65 may be treated differently than another person with a 0.65, depending on the clinical scenario. So if they went from a 0.9, a month ago, now they're 0.65, and with new symptoms, then I'm putting them in the hospital. As opposed to if they're 0.68, 6 months ago, they're 0.65 now, nothing's changed. Well, then I'm going to change and encourage that person to make lifestyle changes and do other things that we're doing, which we'll talk about later. Disease location, proximal, distal, and proximal and distal could be, in both multi-levels. And most times we see a lot of people with multi-levels. Functional capacity, pain-free walking distance, maximum. Some people are just limited. And oftentimes these people who have bad peripheral vascular disease and their functional status is limited by the peripheral vascular disease, that could be masking significant coronary disease. So we have a patient coming in and they have bad peripheral vascular disease, and maybe they, have some ischemia to the toe, etc. They may need surgery for these disease. However, the same person can have a left main coronary artery disease, and you're going to be recommending for vascular procedures. These vascular procedures are probably the most, some of the highest risk surgical procedures in the setting of people with coronary disease. So oftentimes it can be tricky with these patients in the setting where they have bad, claudication. So I don't walk very much. Well, okay, you don't walk much, but then you may have angina that we're not seeing because you're not active, because of the peripheral vascular disease limits your activity level. Tissue oxygenation, I've used this before in patients in the hospital. These are people with severe peripheral vascular disease, and we do what's called transcutaneous oximetry. And these are people we're trying to evaluate. In most cases, where I've used it, we're trying to evaluate whether they're candidates for hyperbaric oxygen therapy. These patients do well with hyperbaric oxygen therapy if they have some evidence of flow or oxygen delivery, so that shows some level of reversibility there. Oftentimes, it requires revascularization and hyperbaric oxygen therapy as concomitant treatments. And then, of course, concomitant atherosclerotic vascular disease. They can have, subclavian artery disease or carotid artery disease or coronary disease. And frequently, these patients have all of the above. And so this is something that you want to be aware of in terms of evaluating these patients and thinking about these patients. As alluded to earlier, conventional coronary angiography is what's done. We've had patients where we had to send to the hospital emergently do angiography. There's a patient I presented in one of our talks several months ago who had an embolus to an artery. He also had peripheral arterial disease, but he had cardiomyopathy due to amyloid and had some atrial arrhythmias, and that resulted in embolization. He had to have emergency surgery. So these patients can have a lot of comorbid conditions, and the management can be very complex in terms of getting them out of one. And so they may have to have emergency vascular surgery, which is a high-risk surgery in the setting of, say, heart failure, cardiac arrhythmia, or coronary disease. And so how you manage these patients is really important from the global standpoint. And I'll share some thoughts with that later. CT and MRI are also diagnostic options for patients when it's not as urgent in terms of maybe needing urgent therapy. And as alluded to earlier, the main goals is reducing risk of adverse cardiovascular outcomes. Remember, the way these patients die is due to cardiovascular events, heart attack, in some cases stroke, but heart attack, stroke, sudden death. The peripheral arterial disease, the lower extremities, typically lead to morbidity problems, most related to amputations. Rarely do people die from this, to die from gangrene, because by the time they get gangrene, they rush to a hospital. Most hospitals can do amputations and give antibiotics. But you want to try to prevent that, and so you want to preserve limb viability. If they have toe ischemia, infarct, you can amputate the toe and hopefully not have to amputate farther up. So they talk a little bit about treatment beyond surgery, hyperlipidemia, managing surgery. So in this article, they talked about two studies, well, actually one study in a registry data. The study was called Heart Protection Study, and the subgroup of patients that took simvastatin, they didn't mention a dose here. I'd have to look that up, but I would imagine it's probably simvastatin at least 40, probably simvastatin 40 or 80 milligrams, because you have to have an intense dose. They saw a 25% reduction in the treatment group, and this is a reduction in cardiovascular events compared to placebo, and that was over a 5-year period of time. There's a large registry study that was done, and I'm going to go through that algorithm in just a minute, of patients with peripheral arterial disease who were taking statins, and they had an 18% lower rate of patients, 18% need for revascularization and amputation in the patients on the statin. So there's evidence that you can reduce morbidity and mortality, or primarily morbidity, in the patient with statins and peripheral arterial disease. Now, when you look at this treatment algorithms, these things are kind of handy. I may follow this loosely, not so much. A resting ABI 0.91 to 1.4. Administer exercise test. So sometimes you can have a normal resting ABI, and then you do an exercise ABI. And if it drops in the abnormal range, i.e. yes, and is symptomatic, then you take them over to this category here. So at rest, they may not have problems, but if they're symptomatic and like claudication, pain, or whatever, and it drops to 0.9, then that shows that they have more advanced disease, than you know. If they're not, then you're going to treat them with cardiovascular risk factors. I'm going to go to this in a minute. If it remains normal with exercise, then you go to other potential cause of leg discomfort. Sometimes people can have neuropathies, they can have arthritic conditions, but even neuropathies and arthritis can be due to microcirculation. We looked at our discussion on the Beamer therapy at the microvascular disease can result in tissue discomfort. And so you may not have the same clinical syndrome that you have with claudication, which is large vessel disease, but microvascular disease, which can then affect nerves and collagen tissue, because all tissue needs blood flow. And so even though you're looking for other causes, you may say, well, this is neuropathic, or this is due to inflammatory disease of the joint and musculoskeletal system. That too could still be microvascular disease, but we'll talk about that in the other in part 2. So resting ABI from 0.5 to 0.9 is sort of mild, moderate, and severe. Or ABI resting greater than 1.4. This is like moderate and severe, and this is mild. And this could be due to a stiff or calcified artery. they say measure toe brachial index. If that's abnormal, you take it down this whole management disease. So if it's mild, administer exercise tests to assess functional capacity. If it's moderate to severe, perform transcutaneous oximetry is what they recommend. And then you take it down this treatment, reduce cardiovascular risk, high intensity statin, treatment of hypertension and diabetes, smoking cessation, antiplatelets, aspirin, or clopidogrel. Clopidogrel was found, I think later on we'll mention this in an article, clopidogrel was found to have better efficacy than aspirin. You want to improve functional capacity, supervised exercise. Cilostazol also it reduces symptoms, allows you to exercise more. Revascularization if no response to exercise medication. Treat coexisting conditions, follow up, assess adherence to lifestyle change. Lifestyle. There we go. And drugs, and monitor for stent or graft patency in patients who've undergone revascularization. So that's a common approach. Notice we get a little mention of lifestyle there. We're going to talk about that a little bit more. Those you probably know what I'm going to get at. Hypertension, they don't have any recommendation of one type of blood pressure medication over another. However, there was one study that showed angiotensin receptor blockers work well in diabetics and overall improvement of their morbidity and mortality. Diabetes itself, you want to control the diabetes to improve microvascular disease and neuropathy, and we're going to talk about that more. Smoking cessation. This patient in the presentation had a history of smoking and continued to smoke, so you want to try to stop them from smoking. It's amazing to continue to smoke even after having a heart attack and bypass surgery. You don't treat them with warfarin or Coumadin. That's not indicated here. And here's where we talked about aspirin. Did not have effect on people with ABI less than 0.95. Clopidogrel was more effective than aspirin. This drug, Verapazar, is an antiplatelet. And by the way, for arterial disease, you go with antiplatelets. People with venous hypercoagulability, you go with anticoagulants such as warfarin and some of the novel anticoagulant agents. The exception, which is not mentioned in this article, is Xarelto, which is a factor 10 inhibitor. It's an anticoagulant agent, and at low doses, Xarelto has been found to be beneficial in people with peripheral vascular disease, and it was shown to reduce overall morbidity and mortality. And when they looked at the mortality benefit in that group, a large percentage of people had a reduction in stroke. Now, we know that these anticoagulants are associated with reduction in stroke with people with atrial fibrillation. And so, in fact, I was on one of the faculty panel before the drug was released. And so we had a discussion. They get some thought leaders in the community to talk about this. And one of the questions we raised in that study is that how well do they screen for atrial fibrillation? But then one of my colleagues said something I thought was pretty interesting, is that there could be an anti-thrombin effect that has some overall impact on vascular well-being, because people with atrial fibrillation who have stroke, they don't have stroke just by having atrial fibrillation alone. People with lone atrial fibrillation, in fact, we're going to talk about atrial fibrillation next week, but with lone atrial fibrillation, you don't give anticoagulant therapy because there's no benefit for anticoagulation, no increased risk of stroke. You have to have atrial fibrillation plus other things: vascular disease, diabetes, hypertension, female gender, previous stroke, etc. And then we give you a point system, and then the more points you have, the higher chance you have a stroke, then you anticoagulate those patients. So we know that people who have atrial fibrillation or at risk for stroke have other things that increase vascular, that have an impairment on vascular health, i.e. lifestyle things or other comorbidities that impairs vascular health that predispose to stroke. So this Xarelto probably have some benefit on vascular health through its mechanism of being a thrombin inhibitor. So that's a little bit more in depth for this conversation, but they should have at least mentioned it in this review article, and they didn't. I don't know why, but anyway, it was a pretty recent review article. So anyway, supervised exercise, a program that incorporates walking at least 3 times a week. I'm all for exercise. I can't Cilostazol is a phosphodiesterase inhibitor with antiplatelet and vasodilatory properties. So it does have some benefits in terms of vasodilatory properties and antiplatelet properties. And it's been associated to improve walking distance. And so that drug is being used. Revascularization primarily is indicated from the standpoint of limiting symptoms. So if you have somebody with real bad claudication, you've done all these things, and they still have symptoms, they're saying that you can then do revascularization in that situation. Most commonly, what I see is patients who are more in an acute or subacute setting where you have to revascularize to save the limb. So for limb salvage, that could be in the setting of, gangrene or urine infection where you're trying to prevent amputation, or in the case of the patient I presented not too long ago, the gentleman who had an embolization, had an acute, shut off of blood flow. We had to hurry up and revascularize to prevent loss of limb in that setting. And so, that's the situation. Those are the common areas where you want to revascularize. Here's some endovascular procedures that are typically done. So just looking at the anatomy, you have the common iliac artery, the internal iliac. Some of the more important ones is the common femoral. You have the profundus femoris artery. The patient just recently had a stent placed in the proximal profundus femoris artery. You have the superficial femoral artery. This is an embolization that other patient presented. The popliteal arteries around the knee, and then infrapopliteal arteries. You have the anterior tibial, the tibial perineal, then the perineal artery. Then you have the posterior tibial artery that comes off, and it gives collateral circulation with the anterior tibial in the foot with associated branches. So more proximally, you can do balloon angioplasty and or stent. As you work your way down, again, you still have the option of stent and balloon angioplasty. Sometimes you have to do atherectomy in the setting of calcification buildup. And distally, frequently they use either drug-coated balloon angioplasty or different drug-eluting stents or covered stents are often options as well. So in conclusion, so they discussed this patient that we talked about. So this patient in the vignette, so she should have undergone non-invasive arterial evaluation. And the ABI, had it been less than 0.9, which I'm sure it likely would have been, she'd have been a good candidate for more intervention. I'll talk about my thoughts after the break. She should be counseling for smoking reduction, regardless of what the ABI shows. She needs to stop smoking. They would recommend initiating cilostazol 100 milligrams twice a day. I have a different take on that. They also recommend increasing the atorvastatin to 80 milligrams daily. I have a different take on that. And they said if her symptoms continue to limit her activity, they would recommend angiography and revascularization. An endovascular approach would be the ideal approach to start with if the anatomy allowed for it. So that's the article, and that's their take on things. I'm going to, I guess, render a second opinion, as they say, as I'm often asked to do by my patients who come from different parts of wherever. So why don't we take a break here? I'm sure you all are tired of hearing me talk. So we'll take a break, and then we will come back after the intermission, after you've got a few seconds of not hearing me talk, to hear me talk again. But we'll all talk. Anyway, we'll take a break.